Good morning, students. Today we are going to discuss about COPD. I am going to talk why is COPD important, why should we learn about COPD, why it is important nowadays. So these are the points we are going to discuss about because there is so much change in last 10 to 15 years in COPD management and definition, management, risk factor. So much change happening in last decades. So I am going to discuss about. I am going to overview of COPD. What I am going to speak it. I may speak a definition, epidemiology, socioeconomic burden, pathophysiology, risk factor, diagnosis and differential diagnosis. Let me start with the definition. Definition of COPD recently changed couple of week ago, but we should know what was the old definition. Old definition was COPD is a common, preventable, treatable disease that is characterized by persistent respiratory system and airflow limitation. That is usually due to airway and alveolar abnormality caused by noxious stimuli and gases. What is new definition? New definition has been little easier because there was several issues with the old definition. Some say that definition do not cover all the pathology phenotype which happens in COPD. So now they have come with a new definition of a week ago. What is new definition? New definition is a COPD is a heterogeneous lung condition characterized by chronic lung symptom. What are those symptoms? Dyspnea, cough, expectoration and examination due to abnormality of airways and lung parenchyma, means alveoli, that causes persistent, often progressive and airflow obstruction. This definition covers almost all phenotype of COPD. Now we come to the epidemiology. COPD is a leading cause of morbidity across the globe. It has huge socio-economic burden on the country. Prevalence of COPD is directly related to smoking. But in last few decades, other factors like indoor-outdoor pollution, occupational air pollution has emerged as important risk factor for the development of COPD. COPD prevalence vary country to country, but it has been estimated that approximately 10.3% of population is suffering from COPD. Again, it may be underestimated because almost all the prevalence study has taken SPIROMETRY as a gold standard for the diagnosis of COPD. As I said, it is a third leading cause of death. It is a third leading cause of death. You can imagine globally around 3 million deaths annually occurs due to the COPD. The volume of death speak about gravity of the disease. In our state, Rajasthan, where we live, is considered death capital of COPD. The COPD means COPD is a leading cause of mortality in our state, Rajasthan. Now, as I said, COPD is associated with the huge socio-economic burden. It is around 6% of total health budget. is spending at dealing with the COPD patient. And of this budget, COPD acute exacerbation, most of the budget goes to the COPD acute exacerbation. So we need to learn about COPD because of this much of expense and mortality due to COPD. And hospitalization and ambulatory oxygen, domiciliary non-invasive ventilation carry huge burden, huge economic burden to the family and society and subsequently the country. What happens COPD carry two workforce, two economic workforce. One is patient himself, another person who is take care of the patient. So it carries huge economic burden to the family. The global burden disease study found that COPD is an increasing contributor to the disability and mortality around the world. In 2005, COPD was the 8th cause of daily adjusted life year across the world. By in 2013, it was 5th. Now it is carrying on increasing trend because of increasing prevalence of COPD. Now we come to the pathogenesis. Gold defined pathogenesis in one simpler way. Gold said that COPD is the end result of what? COPD end result of complex, cumulative, dynamic gene-environment interaction over the period of lifetime that can alter, damage the normal development and aging process. Genetic factor, varied environmental factor and lifetime. So this has simplified the pathogenesis by to simpler way. That COPD and result of the various genetic factor and risk factor through which patient is exposed. More exposure, more the chances of development of disease. Now we come to the risk factor. Apart from smoking, smoking is the biggest contributor. Smoking is the biggest contributor. Across the globe, almost 50% of patients of COPD is due to the smoking. Rest 50%, another factor is responsible. It is huge factor. It is till date it was underestimated non-smoking factor. While they are very important in causing COPD, biggest is beside smoking factor as one is indoor pollution, another is outdoor pollution. Indoor pollution, as you can see chulhas, very almost 30 billion population using chulha for their cooking habits. Tobacco, we all know, various tobacco like cigar, like tobacco, cigar, pipe, hookah, various type of. One is dust. Dust is very, very common factor in the construction worker, then the mines. There is lot of dusty works people engage in. Mosquito repellent commonly used in the household people. People involved in the paint industries. Agarbatti we use in our domestic houses. Wood and paper burning. Or last, vehicles, especially diesel vehicles. And as far as outdoor pollution is concerned, various biomass burning, there is a lot of debate now going on in our country about parali, biomass filling, emission I told you, industries, open waste burning, transportation I told you, brick factories, construction worker, and that is the occupational exposure. Some jobs have high risk of COPD development. What are those jobs? One is manufacturing, other is farm work, mining, housekeeping, vehicle. These are the occupation in worker those workers who work in the occupation as are at high risk for the development of COPD. So as I told you, biomass fuel exposure, occupational exposure, air pollution is very important. We have seen air quality index around the Deepavali around 500, 600, 400. Almost all the cities, major cities of our country are polluted. Safety index considered 2.5. We have air quality index over 500. We can see what is the scenario, how we are exposed to this kind of pollutant air. One is the genetic factor. People who develop COPD at younger age usually have genetic factors. Untreated asthma, poorly treated asthma may lead to the development of COPD. Chronic bronchitis, recurrent infection may cause for the COPD. Now pathophysiology, there are basically 5 pathophysiology. One is air obstruction, the gas traffic, very important. Another is the pulmonary gas abnormality which happens at the level of alveoli. Another is the pulmonary hypertension. One is the exacerbation. Exacerbation is very important because each exacerbation reduces the lung function. Or COPD is a disease of elderly people. As we grow older, we acquire some age-related disease like hypertension, like diabetes, like cardiac pathology. COPD, so this is another very important things which need to be remembered. Now we come to the diagnosis. Diagnosis comes from the history. History. What is history? One is symptom. And the symptom, what are those symptoms? Important symptom is dyspnea, cough, expectoration, chest tightness, wheezing, fatigue, not feeling well, getting tired, किसी काम में मन नहीं लगता, बैठे बैठे थक जाता है, शाम को कुछ करने की इच्छा नहीं होती है. तो fatigue is a very important symptom. Other is weight loss, muscle mass, anorexia, swelling, depression, anxiety. Important cardinal symptom of cough, dyspnea, and expectoration. These are 3 cardinal symptoms. This should be supported by the past history of exposure, smoking, family history, pattern of symptom development, past history of hospitalization, past history of exacerbation, and presence of comorbidity. Once we go to the history and exposure, there is time for the physical examination. In early stages, there was nothing to find in the clinical examination, but as COPD develop, clinical signs appear on physical examination. Shape of the chest is changed, high inflated chest, barrel shaped chest, there is cyanosis. What is objective research for the diagnosis for the COPD? History, physical examination supported by the spirometry. As you all have read in your previous classes, PFT used for the spirometry used for the diagnosis of COPD. It is a computerized test. Computerized test. We can easily diagnose COPD. As you see, left hand side is normal volume time curve. You can see sharp spike, a smooth plateau. You can see, we can see, very sharp spike. Right hand side, you can see after twitch changes. It means this spike is not sharp. You can see FEV1 is markedly reduced as compared to left hand side. You can see FEV1 markedly reduced. So, what is the diagnostic modality? What is the diagnostic cutoff value for COPD? COPD is post bronchodilator value is less than 0.7. But one need to be remember that spirometry is a very technical effort and patient dependent test. So before interpreting the spirometry, one should ensure the spirometry is correct. So what we should do? Spirometry should be performed as per guideline, national and international guidelines. Second thing, volume time curve should be smooth. No zigzag, no interruption. Should be smooth. Free form regularity. The pause between inspiration and expiration should be less than 1 second. Recording should go long enough volume plateau to be reached, which may take sometime more than 50 seconds in a severe lung disease. Both FEC and FEV1 largest value should be obtained of 3 satisfactorily obtained curve. There should be less than 150 ml variability. FEV1 FEC ratio should be taken for the technically, remember them, technically acceptable curve with the largest sum of FEC and FEV1. You got? So as I told, spirometer criteria, FEV1 on FEC ratio should be less than 0.7. These are the grading as per spirometry. Easy to remember: 30, 50, 80, 30, 50, 80. FEV1 more than 80 is mild. FEV1 between 50 to 80 is moderate. FEV1 less than 50 severe. FEV1 less than 30 very severe. So 30, 50, 80. Less than 30 very severe. Less than 50 severe. Between 50 to 80 moderate. More than 80 mild. So these very simple to remember: 30, 50, 80. I hope you remember 30, 50, 80. Another is MMRC dyspnea scale. Every COPD patient must be assessed in terms of MMRC dyspnea scale. Very simple to remember: 0, 1, 2, 3, 4. 0 means breathless on strenuous exercise. 1 means, grade 1 means hurrying on the ground. Grade 2 means patient can walk but cannot keep pace with the same age sex people. Same age sex person. Grade 3 means patient become difficulty breathless on pace, about walking 100 meter. Grade 4 is dyspnea rest, breathless rest. Every COPD patient must be assessed in relation to the MRC grade, because MRC grade define the prognosis, decide the treatment, number of things we can decide on the dyspnea scale. This is the CAT assessment. CAT assessment score is a validated scoring system. It is available online. You can download from there. These are every COPD patient must be assessed for the CAT score. Now, in 2017 guidelines, COPD gold come with the ABCD tool. Now this has been changed. ABCD. AB means low risk. A and low risk, low symptom. B low risk, high symptom C, high risk, low symptom D, high risk, high symptom. This has been changed. Now, what is changes? Gold has abolished C and D. They have replaced C and D with the E. Now is A, B and E. Very simple. You can see the spirometric criteria, you can see CAT score, you can see history of observation. So you can see those who are having more than 2 observation or more than one severe observation, it comes to the grade E. Now, when a patient comes of COPD, comes with the acute observation, certain things need to be ruled out before labeling patient as COPD acute observation. What are those things? Asthma, congestive heart failure, bronchitis, acute cardiac event, tuberculosis, obstructive bronchiolitis, diffuse bronchiolitis. These are the things which should be differentiated from the COPD. Asthma, we all know there is a reversible airway obstruction, eosinophil inflammation, response to ice is very good, history is long since childhood. Congestive heart failure, we all know, X-ray shows signs of pulmonary edema, dilated pulmonary veins. Bronchitis, we all know, we can easily view the ring shadows on the X-ray. Tuberculosis, we all know how classical feature of tuberculosis, opposite infiltrated bilateral disease, sputum positive, family history, can easily differentiate with the microbiological test. These are the things that need to be excluded. Next class we will take on treatment part of COPD. I hope you all understand. Anything need you may ask. Thank you.